Hey med-surg students, I'm going to talk now about pneumothorax, tension pneumothorax, and hemothorax. So first I'm going to tell you the causes of each one, then I'm going to go into the assessment and what's different in each one, and then the treatment. Okay, so let's start. Let's talk about pneumothorax first. Now, we have talked about this earlier in the semester. This could be due to a complication, okay, of having a procedure done. Remember, pacemaker insertion. It could also be from Swan-Ganz insertion, from central line insertion, from portacath insertion, permacath, fast cath. So any of these type of procedures can cause a pneumothorax. That's why after the procedure, we do a chest x-ray. We also auscultate lung sounds, right, to make sure we can hear them in all lung fields. And they do the chest x-ray not only to rule out a pneumothorax, but to determine where the vascular device was placed. So also, there are people that can have spontaneous pneumothoraxes, like people with COPD have what blebs on their lungs or bullae, and those can just like rupture spontaneously, and then that person could develop a pneumothorax. Tall, lanky boys are prone, like teenage boys, when they're growing tall, they're also prone to spontaneous pneumothoraxes. So that can be a cause of that. Now, with the tension pneumothorax, okay, this is most typically due to trauma. And what could happen is, say this person with a pneumothorax had trauma, and now they have like this open wound here, right? Well, the air is going in, but it can't get back out. So what happens is all that pushes the mediastinum to the unaffected side. So you're going to see the symptoms of tracheal deviation to the unaffected side, okay? And you'll see JVD because it causes obstruction, okay? And then with the hemothorax, this is bleeding into the lung, okay? And this most typically happens due to trauma. Could probably happen during surgery as well. Now, if it's a simple hemothorax, it means that there's less than 1,000 mLs of blood loss. And if it's massive, it's more than 1,000 mLs of blood loss. So obviously you're going to be looking for your signs of shock, okay? In all these conditions, possibly. The signs and symptoms, when somebody has either a pneumothorax, a tension pneumothorax, or a hemothorax, they're going to have signs, their vital signs are going to mimic shock, right? They're going to have tachycardia. They're going to have weak pulses. They're going to be tachypnic. They're going to have hypoxemia, so their O2 sats are going to be low. They're going to have hypotension. They're also going to be diaphoretic because they're under a lot of stress. They will complain of chest pain as well. So those are kind of the signs and symptoms that are similar. Now I'm going to point out just a couple signs and symptoms that may be different with each one. So with a pneumothorax, you're going to hear hyperresonance on percussion. Now, I know that we don't typically do percussion, okay? However, there are a lot of NCLEX questions about that, about what you're going to hear when you percuss. So with pneumothorax, it's going to be hyperresonance. Tension pneumothorax, the same, okay, because it's just air. And then with the blood, it's going to be dull to percussion, okay? So that'll be the different signs and symptoms with that one. Okay, so some of the treatment. The treatment for all three could be a chest tube, so you would need to get consent, but chest tube is an option. Also with hemothorax, it could also be treated with thoracentesis, and you do need to know the nursing implications of thoracentesis, the positioning, okay, but the complications. There's two very important complications you need to know about. After the procedure, they can develop a pneumothorax, but they can also get what's called re-expansion pulmonary edema, and they're going to have signs of shock. They're going to have like a low blood pressure, high heart rate, and they're also going to be dyspneic, and they'll have an S3 heart sound, and coughing, pink frothy sputum. So you're going to be watching out for that, okay? So with a pneumothorax, the treatment is going to be chest tube, and with tension pneumothorax, if somebody comes into your ED with trauma and it looks like they have a tension pneumothorax, the physician needs to do a needle decompression immediately. So you're going to get a 14 to a 16 gauge IV needle or some kind of angiocath, and the physician's going to insert it in between the second and third intercostal space, mid-clavicular line. They'll decompress that, and then the patient will need a chest tube, okay? So they'll put a chest tube in to drain the air after that. And so, yeah, so that's kind of the difference between pneumothorax, tension pneumothorax, and hemothorax. Now, all of these can be diagnosed with a chest x-ray, okay? All of these, after you put in a chest tube, you always get a chest x-ray. Even when I was in PACU, even though they put them in the OR, when they got to PACU, we always got a chest x-ray after, so the provider can see where the chest tube is, so to speak, okay? And then they'll do serial chest x-ray after that, and hopefully, like every day, they would do a chest x-ray until the chest tube comes out, just to monitor how the chest tube is doing and if they're getting better. So that's basically it. That's with pneumothorax, tension pneumothorax, and hemothorax.